Hello, and welcome to the Everything PT podcast with Matt Taylor and Daniel Bodkin. Please do not consider anything you hear to be medical advice, just a couple of guys ranting about everything PT. Enjoy the show. Hello, Matt Taylor and Daniel Bodkin here with episode number 004 with dealing with all things protocols. You see, I'm ready for at least 999 episodes here, Daniel.
Yeah, I like you got that third digit in there.
Planning for success. Yeah,
we might run out of topics before then, though.
Eventually we'll. That's true. We got a good list here going, I think.
I kind of feel like, I used to have clinicians that I'd work with, people to talk to, get my gossip from. I don't get that anymore. So,
yeah,
this is kind of just like my way to get everything out.
It's been good. It's been good.
I'm not paying you to be my, psychotherapist, but it's kind of like that.
If you are paying me, let me know, because I haven't seen it. Daniel.
I mean, talking to you is a lot different than talking to my 3 and 4.5 year olds. So
yes, my wife would probably say we're on a similar level, I imagine. So. All good.
Not that I don't mind talking about action packed and Spider-Man, but that's neither here nor there. All right, today we're talking protocols.
Protocols.
In the world. Are they good? Are they bad? Are they ugly? What can be done that's better? What are your thoughts?
Yeah. Oh gosh, there's a lot to think about with this, and I remember being a really young therapist early on, and just being terrified of the patient in front of me. And just going through my old books and notes and on protocols and looking up different ones and, Kisner and Colby or whatever you have for protocols too. And just being afraid that I was going to deviate too far. But it's funny, I think 10 years into care, now I basically know a lot of what the gist is of what they have to say. But I remember that fear early on though, of am I going to mess this patient up because I'm not exactly following the protocol. What do you think?
So I actually teach in a transitional master's athletic training program. One of the courses is Rehab. And the thing about it is I talk about protocols a lot because we bring protocols in, but I mentioned how not everything is in a protocol, but we need them. They're kind of like our limits. They tell us when it's safe to do this, when it's safe to do that. But there's a lot of things that aren't in them that as a clinician, there's a lot of things that you should be doing that's not in the protocol. So I talk about that a lot. I've seen, and I know you probably have seen some funny things written.
Oh gosh.
If a doctor handwrites something on the script or on your progress note, they send back to you, you might want to consider doing that.
How are we still getting handwritten prescriptions that no one can read? You take it to the office staff and they're like, I have no, it's like ancient hieroglyphics, and it's 2022. Exactly. We can't get typed prescriptions here. So
we make a lot of assumptions. When the doctor is writing a script to us, or he sends one of his or her patients to us, they're making a lot of assumptions about us. And if they know how we practice, that helps it out. And also you got to know your doctors too, what they like, what they don't like. And a lot of that's going to come from when you market, when you go and you talk to that doc, you got to talk, spend that time wisely, find what they like, what they don't like.
Yeah. Yeah. And we'll pick on orthopedic surgeons that there's a lot on their shoulders. They're seeing, I don't know, 40 to 80 patients in a day. That's a lot. That's a lot for them to keep track of. And I mean, I'm quite sure the first thing they want to do when they get home is crack open a nice, JOSPT and read about, therapy and whatnot. And I know I don't when I work a 10-hour day. And so it's a lot to expect from them, with keep up with the latest and greatest surgery, because it's hard for us too, living such a busy life.
Exactly. They want the best for their patients. You want the best for your patients. So we're trying to use what evidence we have. And I look at the protocols as the minimum acceptable standards. if your patient had a rotator cuff surgery, and generally you would start mobilizing them passively, we wouldn't start working them more actively until week 6 to 8 or so. That's kind of a general timeline. Some doctors are more aggressive, some aren't, but it all comes down to that surgery when they're in that person's body and they see, wow, there's a lot of damage in here. They might come back and say, no, I've seen it, no, passive range of motion for 3 weeks. Like, well, what do you want me to do with them? Smile across the clinic?
Yes.
But it's
Yes.
because they were in there. They saw the extent of damage that they had.
Scalp
So,
squeeze all day, Daniel.
but so here's the thing though, right? There's a lot of things that you can do that's not in there. I see all the time my, rotator cuff shoulders, my capsule repairs, they're in that sling and they're coming in, their pain levels high. They just had surgery a couple days ago. Just doing IASTM or soft tissue work on the scapular muscles, not touching anything that was repaired, but doing soft tissue work. That makes everything relax. Their pain goes down. You don't have to spend a ton of time doing it. That's not going to be in a protocol. Exercising the opposite limb. Doc said, don't do any active range of motion on the side. Don't do any isometrics, none of that yet. But doing those things on the opposite limb has a huge effect. Not only is that going to help this side out from that neurologic crosstalk, but you're preparing the patient. They know what's coming next.
Yeah,
So
I think
you're
it gives
teaching
them a little bit of confidence too, to carry over, like you said, with neurological symptom. And if they're a weightlifter and they can get back in the gym and work their legs or work the, non-involved side, that's going to give them some confidence and just make them feel good too.
Certainly. Of course, when you send that patient back for a progress note and they see on your flow sheet, this person's doing, blue TheraBand 90/90 ER/IR. Make sure you write that it's the opposite limb. I've had that problem. The doctor, I can't tell you if I actually wrote that it was the uninvolved limb, but they came back and I said, absolutely, no range of motion, stop doing resisted. So then I had to let them know it's the opposite arm. So again, communication is huge for that. But if that doctor knows that you like to work the opposite side because you've communicated it with them, that'll be big. What are some of the funny ones you've seen?
Oh gosh. I love when I get a prescription and it's usually from, I love the primary care docs. If you're listening, I love you guys, but all the checks, for physical therapy. And then there's like every modality you've ever heard. And then there's that one that's really diathermy is on there too. We check diathermy, ultrasound, moist heat, drying needling, IASTM, just everything, cross friction massage, active real stretch or whatever, everything is checked. So,
and that's good. The doctors don't know what you do day to day. They're not in your clinic. They're not a PT. And lots of times they're checking those boxes because it's on their paper. They check, 3 times a week because that's what was always done.
Yeah.
Things are different now than it was 15 years ago.
Oh, yes.
So let's say, and I've had this all the time, the patient has a limited number of visits. They have 15 covered visits in a calendar year. And they're somebody who had a rotator cuff repair or an ACL repair. I know we're going to blow way beyond that. And many times you convert them to a private pay at that point, but sometimes they can't cover that amount. And so you can always try to get them on some kind of a payment plan, but sometimes you just have to ration it. In that first week, do we really need to have you come in 3 times this week? Or come in for your eval. I'm going to tell you what to do. Let me see you 1 time next week. I'll tell you what to do. In the meantime, follow up on the phone. We have internet now. We can do virtual visits or even just checking in.
Yeah. And like, I know you and I both love to treat ACL, invested a lot of time and worked with some people with that. But, that's true. You're going to need a lot of visits because the prognosis is such a long discharge plan.
Absolutely.
There. So having them, around that lull, where the quad is just not responding of months, 4 to up to 9 or even longer sometimes too. Yeah. You can just say, hey, listen, go do squats, deadlifts, step ups, whatever, and give them a list and say, go complete these and come back. And in a month and we'll test you again.
And this is making the assumption that we have good compliance. You tell that patient, make sure you're doing your wall slides, make sure you're mobilizing your patella, make sure you're doing your range of motion, again, just for like a post-op knee. And you're making the assumption that they're doing that and you feel good. And then they come back and they haven't done it. And that knee can't get straight because they haven't been doing, any of the extension exercises. Now you're behind the curve. So lots of times the doctors want them to be seen 3 times a week to make sure they don't have those issues. I've also seen high copays. Let's assume they don't have a limited number of visits, but they're paying $100 a visit until they meet their deductible. We'll say it's January 1st and they haven't touched a penny of their out-of-pocket costs.
Oh, yep. No,
And they can't pay that. Let's say it's a $3,000 deductible and they tell you right away, I can't afford that. So how do you ration it then? I've had transportation issues, patients that share a car with their husband or their kids, and they just tell you, I can only make it in once a week. It might be their work hours too. So a lot of it has to go on their home exercise program, communication with the patient. But again, you have to communicate that back to the doctor.
Yeah. Side note here, just different setting. You and I both love the outpatient world, but I remember doing home health for a while. And if you broke the frequency that you set and, you and the doctor agreed upon, big deal. You have to call, get a verbal order. Is it okay that we did this? So some settings really take it very, very seriously. So outpatient's one that I think we got to take seriously. But at the same time, we got to also give the patient things that we know are going to make them better and that are going to improve their outcome too, but staying in. I try to put that in my initial evaluation when it gets to the plan. I say it's recommended that we see them 2 to 3 times a week, but due to patient wishes or whatever, we're going to do 1 time a week. Now, if the doctor actually is able to take the time and even see that, because it seems like our notes we're sending to the doctors are like 5 pages long nowadays. Are they actually going to see that line in there that I said, hey, we're only going to do once a week for the first month and then go twice a week and then go back to once a week at the end of the plan of care? They might not be able to see that. Yeah. So that's a good time. That might be a good time to talk about, communication notes for doctors and physicians and what they want to see. That's a really good opportunity for you to give this to the patient. We fax one and then we also can and give one to the patient. And that's a good time to say, it might be good for, Mrs. Smith to start some active range of motion if there's nothing written on there, or she's being really held back for whatever reason. So, well, I've even seen sometimes that the patient, the doctor, his patient was a meniscus repair, a high school female athlete, and he wanted to go with a more progressive range of motion plan. It wasn't the 0 to 90 for 6 weeks, limited load bearing. He wanted to push her motion. She wasn't my patient. She was a colleague's. And he was really trying to get her, to 110 degrees because that's what the protocol said. And every time he did, he was just flaring up that girl's knee and it was holding her back even more. And, communicating to the doctor that, hey, maybe we should just hold back a couple weeks because she's getting irritated. And, she was very hypermobile anyway. I was telling him, like, she's hypermobile. She's going to get her motion. You don't need to push it. But he said the doctor really wants to use these metrics for range. So that's when you kind of get in a pickle right there. Yeah, no doubt about it. I mean, another story comes up to mind, like this, we'll pick on the rotator cuff and the surgeons, but no external rotation for like 12 weeks. It's alarming. That's alarming too. And, but you were allowed to do full active range of motion with shoulder elevation. And you obviously need some external rotation to elevate the arm, if not all. And again, it might come down to that surgeon went in there to do the repair and there was not a lot of tissue available. Sure. So it might be something that we're not aware of. But again, communication is big. I've seen also, I used to get a lot of, McKinsey only for my low back pain patients. That used to drive me insane because,
I think McKinsey has its place in rehab,
For sure.
but damn it, they have to pick something up at
Yeah.
some point. Especially this has been, I was working out in rural Tennessee, and people would come in and they were telling me what they did over the weekend, and I wasn't even coming close to matching that with rehab, and they were certainly going outside of the limits their doctor would want them to go to. But later in the rehab, it's like, okay, we've gotten as far as we can with McKinsey. Your pain is gone. I need to make sure you're not going to be back here in 3 months when you hurt your back again.
Mm-hmm.
So I had that with docs where they only wanted that. But then, by communicating with them, letting them know that we're transitioning them to an exercise program,
Yeah.
that it worked out. But again, it was because we communicated with it.
I think the best therapists I know are excellent communicators. I think we could always get better at communicating, and that's why whenever we are talking to doctors, it's really important to not badmouth them or tell them they suck or they're doing awful, their protocol sucks, but just hey, this might be some good things I've seen from the past that's helped, and it might be helpful here. What are your thoughts? And then you get to hear their rationale, and then you learn from it too. We all need to be willing to learn and to work together. So
certainly. I've had some doctors that were very anti-manual therapy for their spine patients. And you just knew that doctor did not want you to do any kind of mobilization or manipulation. Or actually, it's usually they would say no manipulation. And so then you'd have to communicate with them. Is it okay if we do cervical mobilization? If they have stiffness in their lower cervical spine, are you okay with me doing that to mobilize that, maybe to unload the upper cervical? Again, that's just that communication coming back to the doctor.
Yeah, because it's a delicate thing, being in private practice, we can't be upsetting people who refer us business here too,
absolutely. When it comes down to it, you're rehabbing the patient. You're not, I should say, you're treating the patient, you're not treating the protocol. I've even had patients that come in and they mention to the doctor, they're just at their normal checkup, their 6-month checkup at their annual. They say, oh yeah, my back hurts me, or my shoulder's bugging me. So they'll write a script for physical therapy, and the patient really doesn't care. Something that they've just learned to deal with. So they'll come in and, I'll go through my spiel. Well, this is something we want to work with you, starting out twice a week, and do that for a month and then taper you down as you're better. And really that patient just showed up because their doctor said you should go. Yeah. Or sometimes they'll come in and they just want to know, is this something I need to worry about? Or is this something I can handle on my own? And, that's when it's like, okay, you have to recognize this person's only going to be here 2, maybe 3 visits. Initial day, check in. And lots of times they just want to check in on the phone with you a week later just to see how's that program working. And then one final visit if they need it. And I think that was something that I learned a few years after practicing, that to recognize when that person gets there, and again, asking them what they want. And lots of times they'll tell you, it's like, I just want to know, is this something I need to worry about? Or
no, I was just going to say, have you ever seen a protocol on the other side of that is just like pages and pages long? It's like detailed by the exercise, how many reps and sets, and it goes week to week to week, and which exercises to progress and which ones to I'm just blown away. I've only seen one, and it was from a patient had FAI, and she went to somewhere in Minnesota, and I got a specialist by a hip guy, and now I'm starting to see it recirculate. More, I'm starting to see this protocol from Pittsburgh now too, but originally I saw it there. But any thoughts about that?
I'm okay with it. There's some groups of docs that were out in Nashville or outside of Nashville that they had their own protocols, and they were particular, and it was never outside of anything I ever recommended or would naturally do. I tend to be progressively conservative. Okay. I don't want to hurt anybody. So I like to progress people, but I like to take, if there's this step to this step, I like to do 2 or 3 steps in between. And so I don't mind it with that, so long as the doctor, again, they might've just gotten that a protocol off the internet and just put it in their folder to send you, but they may have actually taken the time. Maybe they sat down with their own PTs in-house and came up with what they wanted their their protocols to be.
I agree. I think it does a couple of things for the our field chronically underloads patients.
Mhm.
We're notorious for underloading patients. So I think a really detailed plan like that in place or protocol could elevate one of those therapists and just like sets and just total volume, getting that patient's volume, their load tolerance up. Whereas someone who does a lot of this stuff, like we'll say you, for example, if you notice that they're not struggling with hip internal and external rotation, you're not going to have them in prone, and doing windshield wipers anymore. Let's skip that one. But the protocol has us doing it for another month.
Exactly. And
Exactly.
that comes down to evaluating them, assessing them throughout, knowing when they're ready to move on to something else, knowing when to hold back, even though it might be, it's week 12, we're running today for our ACLs, but they're flared up from the last time they were in the clinic. Or I use this example all the time. They went to a music festival over the weekend.
Oh
They
yeah.
were on their knee and it's flared up. Well, we ain't running in week 12. The plan today is just to get your knee to calm back down.
Yeah.
And do what we can do. That way we can run next week, even though it's on that protocol. So they're great for, I agree, they're great for new grads and they're great for even for us to continue to go back and review, but it's not a step-by-step process. You have to fill in those gaps.
Yeah. Would that be your idea of the perfect protocol? Is it out there? Does it exist? We'll say within the surgery.
I'm going to read this from the notes you sent me. The ideal protocol would be some light guidance with room to use your PT brain.
Yeah, I love that. Right. I feel like that hits the nail on the head. I do.
I don't mind an eval and treat, especially if it's an insidious onset kind of thing. I like it when doctors will just say knee pain eval and treat, shoulder pain eval and treat.
Yep.
Versus, it's something they spent 10 minutes with the patient. They didn't have a chance to dive deep into it versus, so them leaving it up to me versus just sending me their anterior knee pain protocol.
Yeah. I think you're right. I think some light guidance, really a good thing. And I think it kind of covers the new grad or therapist is just kind of checking out every day at work. You know what I mean? Because I see those people come in here and I'm like, oh yeah, total knee, rotator cuff, ACL, especially, like we are looking for these patients because I like to think we're going above and beyond what anyone around this region knows about ACL. So, but yeah.
Well, and protocols change too. So guys like you and I that we've been out for a while, we're getting kind of stuck in our ways a little bit. It's good to look at those to remind yourself of, maybe something's changed, that we're just not, that doctor is using a new technique. And with this technique, you can start something early. So an example, Tommy John's, I was getting patients from the Andrews Clinic when I was in Nashville, and they were using an internal brace technique. And so things were being done faster. So that was new to me. Or a hip, they're always getting better at the FAI surgeries. So the hip protocols that we had when I came out 10 years ago, they're a little different than they are now because we're learning. So protocols change. There's a million of them. You can look them up online.
Let's go for the total hip. You're talking about the hip. There's not even a lot of therapy being provided because the hip surgery has come so far, at least in this region, of the country. So are you seeing that too, Daniel?
Oh, I'm not. I mean, I've been out of that for 3 years. But when I was in Nashville, pre 2019, we were getting a good amount of total hips. Yes.
Okay, gotcha.
But again, they were in and out. We'd start them right away. Yeah. And they were discharged around 6 to 8 weeks. Now I did have a few young patients. I say young, I'm in this category now. They were in their 40s having their total hips. And they were very different. They were very active. They were athletes. I even had a police officer. He had one total shoulder done and then the other one done all within a year. And, this guy was in amazing shape, not just because he was in his 50s. This guy was just in awesome shape. If he pulled you over, you would have instant respect for him. He was jacked. But getting him back after a total shoulder, that protocol was very different. Again, didn't change anything in the beginning phases,
Yeah.
But in those intermediate and advanced phases, this man might be fighting for his life. So we have to get it strong. He needs to have as much range of motion as he can. He needs to have strength in that full range of motion. A lot different than, you know, if my mom had a total shoulder done. Very different rehab.
For sure. For sure. I agree. Dan, did we about cover it all here?
I think we did. If not, I'll have to cut a whole bunch out so we don't go, you know, too far above 30 minutes. Because people, let's be honest, people stopped listening after 10 minutes.
They pretty much, yeah, we probably lost my mom and your grandmother.
Yeah.
Whatnot.
I don't think my wife cares.
My wife was scrolling on her phone within literally not even a minute. She didn't last a minute on the YouTube.
I don't blame her. I wouldn't want to listen. Yes. My wife is very introverted. I'm very extroverted. So the less she has to hear me talk, the better.
Same here. Same here.
So for those who have hung in, we have 2 big guests coming up. I'm not going to tell you yet because you got to dangle that carrot a little bit. Huge guests next week. Even bigger guests the week after that, even bigger guests the week after that, and another big one. So we're at least 4 or 5 people lined up. So those are going to be exciting.
Oh yeah. Can we give the topics perhaps? Or you want to tease that?
Let's hold off on that because really the topics I have are just their names. You never know where they'll go with it. But all
right, we'll hold off on the topics. Big teaser. But yeah, I'm excited. It's gonna be cool. If nothing else, we get to really meet and interview some really freaking cool people in our field.
Again, I mean, I say you are my psychotherapist. You could be a figment of my imagination. I could just be sitting here talking to my computer. So it could be. Thank you for
AI over here, you know.
All right, everybody. That's it for today. Thanks for listening. Subscribe, whatever you're listening to on YouTube, Apple Podcasts, or Spotify. Go ahead and click that subscribe button. Send us some comments. I think that helps the algorithm a little bit too. And I appreciate you. Keep listening. Thanks.
Sweet. See you guys. Bye.